It's a tremendous privilege to have the opportunity as a gynecologist to have patients place their trust in me to discuss and treat these sensitive GI issues. Although I'm not physically present with you today, it is my honor and privilege to be able to discuss this topic with you. In today's presentation, we'll discuss the prevalence of constipation. Spoiler alert, it's likely more common than you think. Review the causes, symptoms, evaluate treatment of constipation, and finally discuss some constipation tips and tricks. So how common is constipation? There's often a misconception that constipation only occurs in the elderly. However, approximately 16% of the general population have, with up to 30% of children and up to 50% older adults suffering with constipation. This is an incredible condition and affects patients of all ages. Although some people experience lifelong constipation, many people tend to have intermittent constipation. This often occurs with changes in routine, such as traveling or diet changes, or with hormone fluctuations. So what causes constipation? Typically, constipation is divided into 3 general categories. The first category is normal transit constipation, in which the stool moves through the colon normally, but the stool lacks water and is typically hard. The second category is slow transit constipation, in which the stool is slow to move through the colon. This is often due to a colon that does not squeeze adequately. This is sometimes, always, associated with disorders that affect connective tissue, muscle function, or nerve function. This would include diagnoses such as diabetes, multiple sclerosis, and Parkinson's disease. The third category is evacuation disorders. Many people believe having a bowel movement is simple and easy. However, numerous muscles must contract or in a well-coordinated fashion in order to have a bowel movement. If one of the muscles is not working as part of the team, this can impair a person's ability to pass stool. For example, one common cause of an evacuation disorder is when the anal sphincter, the muscle that should relax and open to allow stool to exit the body, does not open. In some cases, this muscle may even paradoxically contract. Thus, the person is attempting to push stool out against a wall instead of an open door. There are also structural abnormalities, such as rectal prolapse or a rectocele, that can impair stool passage out of the body and result in constipation. Rectal prolapse is when the rectal tissue sits outside of the body. A rectocele is when the tissue wall that keeps the rectum in place weakens, and the rectum can bulge forward into the vagina or bladder, or sometimes backwards. This bulging creates a pocket for the stool to push into instead of being pushed out through the anal opening. Pelvic floor issues are often associated with pelvic surgeries or vaginal deliveries, particularly with large babies or large tears. It is also important to understand that evacuation disorders can occur simultaneously with either of the first 2 categories. Keep these 3 categories in mind, as we will come back to them when we discuss constipation treatment later in this presentation. You may have noticed I didn't mention diagnoses on the prior slide. When discussing constipation diagnoses, things get a bit muddy. One of the most frequently asked questions that I get related to constipation diagnosis is this IBS with constipation or another type of constipation? This is often a bit challenging, but one key thing to note is that IBS is a diagnosis that always has abdominal pain as an associated symptom. For today's talk, we're going to talk generally about constipation and leave the discussion of IBS with constipation versus other types of constipation for another talk. What are symptoms of constipation? Symptoms differ from patient to patient. The most common symptoms people often associate with constipation are hard or infrequent stools. But what are infrequent stools? What are hard stools? I have patients who have a bowel movement some once a week, and others who only have a bowel movement once per month. Traditionally, it was recommended to have at least one bowel movement every 1 to 2 days that is soft and easy to pass. However, constipation can certainly still be present if someone's having daily bowel movements, if they are not having complete bowel movements. In a similar vein, people who only have a bowel movement every 3 to 4 days don't necessarily have constipation if they're having complete evacuation of stool without straining during bowel movements. Thus, constipation is a bit more complex, and the diagnosis is often made after taking a thorough history, including the presence or absence of other symptoms listed on the table. In particular, patients will often tell me, I have a bowel movement at least once a day, but I don't feel like I'm getting it all out. I feel like I need to pass more stool. This feeling of inadequate stool passage is called a sense of incomplete evacuation. This symptom gives me a strong indicator that constipation may be present. Another symptom of constipation is diarrhea. Yes, diarrhea actually cause something called overflow diarrhea. Think of it as a river flowing over rocks. The liquid stool is able to flow over the hard, bulky stool and exit, but the stool rocks remain in the colon. Patients with overflow diarrhea may describe passing both hard and liquid or mushy stool in the same day or even within the same bowel movement. Fecal incontinence can also occur as a constipation, particularly if there's a large amount of stool in the rectum. Unfortunately, the anal sphincter, that muscle right at the end of the colon, is typically good at keeping solid stool from passing involuntarily. However, liquid stool is more challenging to keep inside and can leak out around the bulky rectal stool. Talking about bowel movements is challenging and understandably a bit uncomfortable. Thus, the Bristol stool chart was developed to aid in this discussion. Stool types range from type 1, which is hard, pellet-like stools, to type 7, which is more liquid stool. A normal bowel form is typically type 3 or 4. Types 1 to 2 indicate constipation. However, as discussed a few moments ago, constipation can be present with a wide range of stool consistencies, particularly if there's a sense of incomplete evacuation or overflow diarrhea present. How do we evaluate constipation? One of the first things we look for are concerning for a more serious underlying cause of constipation, such as cancer. These symptoms are known as red flag symptoms and include weight loss or rectal bleeding. If any red flag symptoms are present, colonoscopy is recommended. A colonoscopy is when a flexible tube with a camera and light on the end is used to look at the colon. A physical exam is performed, often including a exam to evaluate for pelvic floor dyssynergia, the disorder I mentioned earlier when the pelvic floor muscles do not work together in a well-coordinated fashion. The provider will also look for anything obstructing the anal canal, such as a tumor or polyp. Depending on the patient, a provider may perform additional testing to rule out anemia, which may indicate blood loss from the GI tract, or they may rule out a thyroid issue, the colon to slow down. To evaluate for those evacuation disorders, anorectal manometry can be performed. This uses a small, flexible tube about the size of a pen with small sensors attached to it to evaluate the strength and coordination of the anorectal muscles. Defecography is a study of contrast placed inside the rectum and X-rays to evaluate for structural problems such as the previously discussed rectocele or prolapse. There are some tests to evaluate colon transit and slow transit constipation. However, these are less frequently used as time intensive and are often only ordered if they'll lead to a change in management. Evaluation also includes reviewing any medications, and the list of constipating medications is quite long. I have listed a few of the most common ones on the slide, but some of the most common medications for constipation are blood pressure medications. Something I also see fairly commonly is the use of hyoscyamine or dicyclomine to treat abdominal pain due to intestinal spasm or diarrhea. This is often very appropriate. However, if the pain is due to constipation and the associated spasm from that, use of these medications to treat the spasm works in the short term, but it makes the underlying constipation worse. This can increase constipation and abdominal pain symptoms in the long run. The same issue occurs when these medications or Imodium are used to treat diarrhea, but the diarrhea is actually due to that overflow diarrhea we were talking about. There can be short-term benefit, but the underlying cause of constipation remains untreated. A vicious cycle of constipation and diarrhea and constipation can occur. This highlights why it is important to understand if constipation is contributing to individual symptoms. If there are no red flag symptoms and other causes of constipation, such as thyroid dysfunction, have been excluded, we need to move on to treatment. When we think about treatment, I like to think of 3 subcategories we described earlier. I try to determine what the primary driver of constipation may be. For example, is it a lack of water or fiber in the diet? Is it a patient with multiple sclerosis and have slow transit? Or is it a patient who has to strain to pass even or mushy stool, and I'm concerned there's pelvic floor dyssynergia? We will discuss treatments more in depth in the next few slides, but understanding the potential cause of constipation may help identify more effective therapies. For example, if a patient with slow transit constipation comes in, they may respond better to exercise or a medication that improves colon squeezing, instead of using fiber supplementation, which can result in more bulky stool that the slow colon has difficulty pushing through. Similarly, if there's a high suspicion for pelvic floor dyssynergia, pelvic floor physical therapy may be pursued sooner. Admittedly, it's not always possible to determine which subgroup of constipation a person has, and constipation severity occurs on a very broad spectrum. Some people have constipation a few days a year when traveling. Some people have constipation for a few months during times of stress. And some people have constipation their entire life. Treatment recommendations are often escalated based on severity and frequency of the constipation symptoms. The first step is in lifestyle modifications. These include increasing water intake, fiber intake, and activity. Adding prunes or kiwi into the diet can also help. I often get asked about probiotics, and some patients report benefit. There's little evidence supporting use to treat constipation at this time. There's some ongoing studies to determine if specific diets, such as the low FODMAP diet, are effective at treating constipation. If diet and lifestyle modifications are not effective or incompletely effective, there are many over-the-counter treatments available. Frequently used options include fiber supplements and stool thinners. It should be noted that increasing fiber may cause increased symptoms in patients with slow transit constipation or evacuation disorders due to the colon having to handle more voluminous and bulkier stool that it has a hard time moving through the colon and out of the body. Fiber can also cause bloating and should be increased slowly after initiation. Medications such as Miralax or magnesium help keep inside the colon, and stimulants such as senna or bisphosphonol promote the colon to squeeze and push stool through the colon. Although Miralax and magnesium are safe, to use daily use of stimulant laxatives is typically not recommended. Enemas or suppositories can also help promote stool evacuation, and in particular help expel any hard rectal stool. Stimulating the anal area when using an enema or suppository also promotes the colon to start squeezing. If diet, lifestyle, and over-the-counter are not effective, prescription medications are typically the next step. These medications often act by increasing water secretion into the intestines or by increasing colon squeezing. These treatments are more often used in patients with more persistent daily constipation. These treatments can also be used with many over-the-counter treatments. Another important therapy is for patients in that third group, evacuation disorders. For pelvic floor dyssynergia, where the muscles don't work in a well-coordinated fashion, pelvic floor physical therapy with biofeedback therapy is recommended. This is a specific type of physical therapy that helps retrain the muscles to work together in a well-coordinated fashion again. Acupuncture has been used for constipation. There is some good data supporting its therapy or its use for constipation treatment. A unique treatment currently being tested is a vibrating capsule that is swallowed and uses vibration to help promote stool movement and passage. This isn't ready for prime time yet, but something to keep in mind to come. It's an entire team of experts from many different specialties that work together to treat patients with constipation and evacuation disorders. From dietary, physical therapies to surgical treatment of anorectal structural disorders, a comprehensive approach to constipation management is recommended. This is particularly important for patients who have severe, persistent symptoms. If constipation is not treated, it can lead to complications, hemorrhoids, anal fissures, diverticulosis, or even pelvic floor dyssynergia. Final tips for constipation management. Be proactive at preventing constipation before, particularly if constipation tends to occur during specific times, such as traveling, during the winter, or during menstruation. Allow yourself enough time to have a bowel movement. It is normal to have the urge to have a bowel movement after meals. This is called the gastric reflex and is a signal sent from the stomach to the colon during meals. Our bodies are smart, and they say if there is cargo coming into the stomach, cargo needs to be sent out of the colon. Try to not signal to have bowel movement. Try to avoid daily use of stimulant laxatives. Seek medical care if new constipation, chronic constipation worsens, or red flag symptoms develop. Diet, activity, and hormones often change, and so regimen. It is okay to adjust the regimen based on what your body needs at different times. I've included a few questions that you want to ask your doctor if you're suffering with constipation. What is the most likely cause of my symptoms? Are there tests I need to evaluate the cause of constipation? And how do I need to prepare for them? What treatments do you recommend? If the initial treatment doesn't work, what will you recommend next? Do you have a dietitian available like you? Are any of my medications potentially causing constipation? Thank you for your time and attention and for the opportunity to speak with you today about this important